In this next lecture, we're going to discuss pneumonia again, but this time we're going to focus on ventilator-associated pneumonias, lung abscesses, and PCP pneumonia. Healthcare-associated pneumonia, or hospital-acquired pneumonia, is defined as a pneumonia developing greater than 48 hours after hospital admission. These pneumonias are extremely important to differentiate from community-acquired pneumonia, mainly because there's a much higher incidence of gram-negative pneumonias, such as E. coli or Pseudomonas. In addition, the management is different. In a hospital-acquired pneumonia, the main difference is that macrolides are no longer acceptable as empiric therapy. The therapy instead is centered around gram-negative rods. Therefore, anti-pseudomonal coverage must be given. These would include cephalosporins cefepime or ceftazidime. These are third and fourth generation cephalosporins with good anti-pseudomonal coverage. In addition, an anti-pseudomonal penicillin can also be used. This would be piperacillin tazobactam. In addition, you could use a carbapenem. These would be imipenem, meropenem, or doripenem. All of the above-mentioned agents have excellent gram-negative rod coverage and do cover Pseudomonas. Remember again, if you're going to use a penicillin, such as piperacillin or ticarcillin, you have to use it in combination with a beta-lactamase inhibitor, such as tazobactam, clavulanic acid. This is the only way that these drugs will be effective against something like Pseudomonas. One type of hospital-acquired pneumonia would be that associated with use of the ventilator, or a ventilator-associated pneumonia. These are important to distinguish from other types of hospital-acquired pneumonia because mechanical ventilation interferes with normal mucociliary clearance of respiratory tract infections. For example, the patient is unable to cough. In addition, positive pressure is tremendously damaging, and it can cause inability to clear colonization of bacteria. Ventilator-associated pneumonia has an incidence as high as 5% per day in the first few days on a ventilator, and it's therefore very important to maintain high vigilance for infection in these patients. Notably, it can be quite difficult to make a diagnosis of a ventilator-associated pneumonia. These patients are often very, very ill and have multiple countercurrent illnesses such as CHF. Things to look out for would include a new fever, one that developed after being placed on the ventilator, or a new white blood cell count, a new infiltrate on a chest x-ray, or purulent secretions coming out of the endotracheal tube that are either increased or different in appearance than those previously. Any of these would be indicative that the patient may have developed a ventilator-associated pneumonia. Unfortunately, sputum culture is nearly worthless in diagnosing pneumonia in these patients. The endotracheal tube is often colonized with various bacteria, both pathologic and non-pathologic. The diagnosis of a specific etiology is therefore very difficult. In order to make the diagnosis, sometimes other means are necessary. Firstly, starting with the least accurate but easiest to do, test might be a tracheal aspirate. You simply put a suction into the endotracheal tube and suck out some contents. Very easy, but very inaccurate. Again, these patients are going to have colonized bacteria in their ET tube. Therefore, it's hard to tell whether what you're getting is actually causing pneumonia. Next, we have bronchoalveolar lavage, which requires bronchoscopy. The bronchoscope is placed deeper in the lungs where there are not supposed to be organisms. You're therefore going deeper than the ET tube goes. However, you can still contaminate the bronchoscope when you're passing it through the nasopharynx. The most accurate test would be a protected brush specimen. However, this is also the most dangerous. In this situation, the tip of the bronchoscope is covered when it's passed through the nasopharynx and then uncovered only once you're inside the lungs. This is much more specific and with decreased contamination. One thing to watch out for in patients who are on the ventilator and may have pneumonia would be the presence of diffuse subcutaneous emphysema, as seen in the chest X-ray on your screen. Subcutaneous emphysema is abnormal. It represents leakage of air into the soft tissue of the chest wall. Causes may include placement of a chest tube, but might also include damage secondary to positive pressure ventilation from the ventilator. The management of ventilator-associated pneumonia involves the combination of 3 different drugs. Firstly, you must administer an anti-pseudomonal beta-lactam. Pseudomonas is extremely common in the hospital and a very common cause of ventilator-associated pneumonia. Options include a cephalosporin, which must be 3rd generation like ceftazidime, or 4th generation such as cefepime. A penicillin, such as piperacillin, can only be given if a beta-lactamase inhibitor is given concomitantly, most commonly tazobactam. Or carbapenem can be given, which might include imipenem, meropenem, or doripenem. However, one anti-pseudomonal drug is usually not enough. We like to add a second anti-pseudomonal agent. That's because Pseudomonas is a bug with lots of antibiotic resistance. Your first drug, either the cephalosporin, penicillin, or carbapenem, might not be enough to kill the certain strain of Pseudomonas that your patient has. Therefore, another one, such as an aminoglycoside, gentamicin, tobramycin, or amikacin, should be given at the same time as the first anti-pseudomonal beta-lactam is administered. Remember, you can always peel off antibiotic coverage later when the patient starts to improve. Lastly, you must also add an antibiotic that goes against MRSA, or methicillin-resistant staphylococcus. Anti-MRSA agents include vancomycin or linezolid. Once you've actually identified a specific organism that you believe is causing the ventilator-associated pneumonia, it is at that time that you can change this initial therapy to narrow your antibiotics for the patient. Let's pause for a practice question. We have a patient hospitalized for head trauma and a subdural hematoma who is intubated for hyperventilation and subsequent craniotomy. Several days after admission, hematemesis ensues and stomach stress ulcers are found. Lansoprazole is started. Vancomycin-associated pneumonia develops and the patient is placed on imipenem, linezolid, and gentamicin, an appropriate antibiotic regimen as we just learned. In addition, phenytoin is started prophylactically. 3 days later, the creatinine rises and the patient begins to have seizures. A repeat head CT shows no changes in the patient's bleeding. What is the most appropriate next step in management? Switch phenytoin to carbamazepine, stop lansoprazole, stop imipenem, stop linezolid, or perform an EEG. The correct answer is C, stop imipenem. The reason is that imipenem can cause seizures. It's secreted through the kidneys, and the renal failure has caused a rise in imipenem levels in this patient, leading to toxicity. This is much more likely than a failure of the patient's phenytoin. The first answer is wrong because carbamazepine is really no more effective than phenytoin at stopping seizures, and less likely to cause renal failure. Stopping lansoprazole, also not likely to cause renal failure. Linezolid has no renal toxicity, and an EEG will add nothing in this situation. We know the patient is having seizures. The key point here is that imipenem makes it easier for patients to have seizures. Moving on to lung abscess, we must remember that lung abscesses are rare because we usually treat aspiration pneumonia successfully before an abscess has a chance to form. It only occurs with large volume aspiration of oral pharyngeal contents, usually in a patient with poor dentition who does not receive adequate treatment. Large volume aspiration occurs from a stroke with loss of the gag reflex, seizures, intoxication, endotracheal intubation, and aspiration pneumonia usually happens in the right upper lobe when the patient is lying flat. That simply has to do with the way that the upper airways are shaped. On clinical presentation, one should look for a person with one of the risk factors for aspiration presenting with a chronic infection developing over several weeks. They will usually have large volume sputum that is extremely foul-smelling because of the anaerobes. Weight loss is also quite common in the setting of an abscess. The best initial test is a chest X-ray. You will see a cavity, usually with an air fluid level. However, chest CT is the more accurate test. Only a lung biopsy can establish a specific microbiologic etiology. In terms of sputum culture, this will always be the wrong answer for diagnosing a lung abscess. Everybody's sputum is going to have anaerobes from the mouth flora, so you have to actually get in there and get a sample of the fluid from that air fluid level in the abscess if you're going to find a microbiologic diagnosis. In order to do that, you have to do a lung biopsy. Here we see chest X-ray demonstrating a lung abscess. You can see the minor fissure demonstrated on the right and an air fluid level suggesting abscess. On the lateral film, we see an air fluid level again and this major fissure separating the upper and lower lobes. There's a very thick wall in this particular abscess cavity. Clindamycin is the optimal treatment for lung abscess, and that's because clindamycin has excellent anaerobic coverage. Let us move on to PCP pneumonia. PCP got its name because it used to be called P. carinii. It has now been renamed P. girovici, but we still use PCP to talk about this disease. It's almost exclusively found in patients with AIDS whose CD4 count is less than 200 and who are not on prophylactic therapy. It also occurs in chronically immunosuppressed patients, especially those on long-term, high-dose steroids. The clinical presentation is usually not very subtle. You're going to see a patient presenting with severe dyspnea on exertion, usually a dry, non-productive cough, but a cough that is quite severe, as well as high fevers. The question on step 2 will often suggest or directly state that the CD4 count is low and that the patient is not on PCP prophylaxis. In terms of diagnosing PCP, the best initial test is usually a chest X-ray, which will show bilateral interstitial infiltrates. Also, an ABG would be an acceptable answer, looking for evidence of hypoxia via an increased AA gradient. In addition, patients with PCP pneumonia will usually have an elevated LDH. This is almost always the case, so if the LDH is normal, you can feel quite confident that the patient does not have PCP. The most accurate test for diagnosing PCP, as we've already mentioned, is bronchial alveolar lavage. As we've said, the sputum stain for PCP is often negative. However, if positive, it is very specific for PCP. If it's positive, there's no need to do further testing. If it's negative, however, bronchoscopy must be done as the best diagnostic test. Remember, with PCP, the normal LDH means you should not answer PCP as the most likely diagnosis. Another tip for step 2 is that this test usually asks you what the most likely diagnosis is, not what the for sure diagnosis is. Therefore, with regard to PCP, remember that you cannot distinguish it from mycoplasma, chlamydia, or viruses by X-ray alone. However, in an HIV patient, PCP is the most likely answer with the presence of interstitial infiltrates. With PCP, the management is pretty easy to remember because the best initial therapy is the same for both treatment and prophylaxis. This involves trimethoprim sulfamethoxazole. You can also add steroids to decrease the mortality of PCP if it is severe. We define severe PCP as a PaO2 of less than 70 or an AA gradient of greater than 35. Alternative therapies if the patient has an allergy to trimethoprim sulfamethoxazole include atovaquone. You can also use this if the PCP is mild and there's only mild hypoxia. If there's toxicity from the TMP-SMX or from atovaquone, you can switch to clindamycin and primaquine. An alternative would be pentamidine. Let's take a look at another practice question. Here we have an HIV-positive African-American man admitted with dyspnea, dry cough, high LDH, and a PaO2 of 63. He started on trimethoprim sulfamethoxazole and prednisone. On the third hospital day, he developed severe neutropenia and a rash. He has anemia, and the smear shows bite cells. What is the most appropriate next step in management? Stop the trimethoprim sulfamethoxazole, begin antiretroviral medications, switch current treatment to intravenous pentamidine, switch current treatment to aerosol pentamidine, or switch the current treatment to clindamycin and primaquine. The correct answer is C, to switch the trimethoprim sulfamethoxazole to intravenous pentamidine. A rash is the most common adverse effect of trimethoprim sulfamethoxazole, and bone marrow suppression is the second most common adverse effect. This patient has both. Although primaquine may have more efficacy than pentamidine, the patient seems to have glucose 6-phosphate dehydrogenase, or G6PD, deficiency, as evidenced by anemia and bite cells seen on the smear. There's no need to stop treatment altogether. The patient needs to be treated for his PCP. Beginning antiretroviral medications should be done eventually, but they will not help with an acute opportunistic infection. Switching the patient's current therapy to aerosolized pentamidine is not correct because you must use IV therapy for active disease. Lastly, answer E is also incorrect because primaquine is contraindicated due to the patient's G6PD deficiency. This question brings us to an important tip for step 2. Oftentimes, students will see 2 correct treatments and think that there must be some mistake in the question. Typically, if this is the case, you should look for a contraindication to one of them. This will serve you well on the USMLE Step 2. With regard to PCP prophylaxis, this is indicated for a patient with AIDS with a CD4 count less than 200. One option is to use trimethoprim sulfamethoxazole. Be careful, this can cause rash or neutropenia. If that's the case, you can switch to atovaquone or dapsone. Aerosolized pentamidine is also an option. It's not used as second-line therapy for prophylaxis. It's really more of a third line. This is because it's less efficacious than either atovaquone or dapsone. Remember, you should always choose therapy based on the efficacy, not necessarily on the adverse effects. Dapsone is contraindicated in patients with G6PD deficiency. Let's pause for another practice question. Here we have an HIV-positive woman with 22 CD4 cells admitted for PCP pneumonia and successfully treated with trimethoprim sulfamethoxazole. She is then discharged on prophylactic trimethoprim sulfamethoxazole and azithromycin. Then she begins antiretroviral medication and her CD4 count rises to 420 for 6 months. What is the most appropriate next step in management? The answer choices would include stopping the trimethoprim sulfamethoxazole, stopping both trimethoprim and azithromycin, stopping all medications including antiretrovirals and observing, stopping all medications only if the HIV PCR viral load is undetectable, continuing all medications, or just stopping azithromycin. The correct answer is B, stopping both trimethoprim sulfamethoxazole and azithromycin. Stopping just the trimethoprim sulfamethoxazole is not correct. The azithromycin must also be stopped. Azithromycin is used as prophylaxis for atypical mycobacteria, such as MAI, and it's used only when the CD4 count drops below 50. Answer C is incorrect because we cannot stop the antiretrovirals. If we do, this patient's CD4 count is going to fall. Again, D is incorrect for the same reasons as C. Continuing all the medications is not necessary. With this patient's CD4 count being 420 for 6 months, prophylaxis for both PCP and for Mycobacterium is not necessary. Stopping the azithromycin alone also is not a correct answer because we also must stop the trimethoprim sulfamethoxazole.